I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
I'm Dr. Randy Martin. I'm thrilled to be joined by Dr. Brian Whisenant from Salt Lake City. Brian, thanks so much for joining us. So you're the clip expert, okay, of the day here. But you're a fabulous interventional cardiologist. But you started back when MitraClip was the E-valve, so you've been doing this for a long time. Where do we stand? I want to ask you about two things. Where do we stand with clip for degenerative, for primary MR, and then obviously I want to get into the COAPT. So where are we with clipping for degenerative MR?
So our current FDA approval is still prohibitive surgical risk.
Right.
I think we have all learned to work together as heart teams in a way that is very patient focused, and we, when our results of MitraClip are as good as they are, that the definition of prohibitive moves just a little bit, because we know we have a very effective therapy that we can offer our elderly high-risk patients, and we have very good results, and we're treating patients effectively with MitraClip now who are higher surgical risk patients. There's been discussion at the Mitral Conclave meeting here about the unmet need for elderly intermediate risk patients, and we're looking for, and we know that there are some trials being contemplated in that space, and looking forward to that.
Are you obviously there are limitations, but if you have extensive calcification of the annulus, is that a limitation?
Yeah, so mitral valve area, I think, is the biggest limitation. Is we can always get rid of MR. The question is, can we get rid of it and still have a good gradient? So if we have small valve areas, that is a limitation, but we treat the majority of patients with degenerative disease much more effectively than we did years ago. I think TE guidance is what has very much facilitated this, and small valve areas, particularly those with calcified annulus, are the real limitations.
That's what I was thinking. Do you, just final question on this, because then I want to get into the COAPT and MitraFR and that whole area, because that's obviously caused a lot of excitement and a lot of questions. How do you quantitate residual MR in primary, in degenerative MR clipping? That's a big issue. I mean, so what do you guys do in the cath lab, in the hybrid room?
Oh, it's a very big question, and it's I hate to have someone who knows echo like you ask me that question, but it's a very difficult question. It's actually nice that we have a recent publication about quantification of valve disease after interventions, correct, and it specifically tells us that quantification of ERO after clip is not valid, and we do see accelerated flow with a higher PISA, and we recognize that that is probably not the way to quantify residual MR, and we've been teaching everyone to get away from just color, but that's really what we do now with MitraClip, is we look at color. And I think we do that both in the cath lab with TE as well as afterwards on our surface echoes, and that's the best we have.
There's a lot of information in the color flowing into the orifice, just the way it looks, the amount of alicing that tells you a lot, so that's interesting. So you were a key investigator in the COAPT trial. You're certainly very familiar with the mitral FR. You made a comment recently, which I thought was just fabulous, that both of them complemented each other. We need both of those studies. So what's the lessons that we learned, just the overview lesson, when we look at mitral FR and COAPT? What are your key messages?
So Alec Fahanian from Paris gave a very nice overview at the Mitral Conclave meeting here today, and talked about how the two trials are complementary. He pointed to the different inclusion criteria based on MR severity, where the MitraFR trial followed the European Society guidelines, which is an ERO greater than 0.20, where the COAPT trial followed the US AHA-ACC guidelines, which is an ERO greater than 0.3. And as a result, the mean EROA in MitraFR was 0.31, and in COAPT was 0.41. So I think that's the biggest difference, is to treat more severe MR. We probably did a little better in COAPT with guideline-directed medical therapy. We didn't have some of the very large dilated ventricles because they were excluded from COAPT. So yeah, absolutely they were complementary. We learned as much from MitraFar about who we should not treat as we did from COAPT about the tremendous benefits we see with therapy.
That was what I was going to ask you. I mean, certainly when you've got very large ventricles that have marked decrease in function, that's probably not the sweet spot.
Especially when their MR isn't severe.
Correct.
And I think this is I think they had both very bad ventricles and not a lot of MR. So these are patients who are not going to do well benefit a lot from a clip.
We know from the MitraClip data that Scott Lim and others, and you may have been on the paper, I'm sorry, I don't know, but did on primary MR and MitraClipping that if you had TR, or you had a bad right ventricle, your outcome was not as good. That message has still got to be there with secondary MR, isn't it?
I don't know that we have the data on that for secondary MR, but I'm sure it is there. And anecdotally, we're all treating more TR now with clips,
right,
both in and out of trials. And we have a large randomized trial that is about ready to start with the Triluminate trial. And MitraClip works better for the tricuspid valve than we would have guessed. And the procedures have become reproducible and predictable and safe, and it's an exciting time to treat the tricuspid valve also.
Am I correct, though, in my assumption that you really should have some knowledge about RV function in those settings, too? I mean, which is a hard thing to analyze.
Yeah, I think we don't know enough. Tricuspid disease, I feel like we're in the tricuspid valve where we were in mitral valve 20 years ago, and that it's a complicated disease with multiple precipitating factors, a lot of different right ventricles, and we haven't done the research and the analysis to understand this enough, and we're still early in this.
So you've was one of the earliest people using eValve MitraClip, and obviously have extensive experience in doing this. Who's going to be doing these procedures in the future? Is it going to be the interventionalist? Is it going to be the surgeon? Is it going to be both?
Well, I don't think there's our specialty dictates who can learn this procedure.
Right.
It needs to be someone who is dedicated to it and puts a lot of energy into it, whether a surgeon or interventional cardiologist. I personally feel like surgeons who spend a lot of years learning to do things that I can't do, we need them as good surgeons. And I think for most surgeons, they trained to operate, and we still need good operators. And I suspect most MitraClips will be done by cardiologists for that reason. But there certainly are a large number of surgeons who are very facile with the clip and do very well.
Well, and I wasn't implying that one should do it over the other, but I think you're exactly right. I mean, I think it's a natural progression. When I look at places where I've been, it's been the experienced interventional cardiologist who's really been engaged in that. There is volume and learning with this, okay? And obviously your colleagues on the COAPT trial were really very experienced operators. As we move into doing more complicated valves, either primary or even a tethered secondary, experience is important, isn't it, to get good outcomes initially?
I think experience is extraordinarily important in the mitral space, and this is a real challenge that we have. It's true for surgery, it's true for MitraClip, it's true in our imaging, and it's going to be even more true with a lot of the new technologies we have coming forward. So we do need to have valve centers of excellence with a whole team of physicians and allied professionals who take a great interest in this space.
Let me ask you a final question. Okay, I could do two final questions. Final question. We're going to have combo procedures for the mitral. We're going to do annuloplasty type procedures, transcatheter and clipping, or some other kind of procedure on the valve. That's a reality?
Absolutely. It's being done in Europe where they're approved. It's harder now where the annuloplasty devices are not FDA approved, but it only makes sense that we'll be doing that. And to be able to, surgery offers patients a durable repair without gradients, without long-term oral anticoagulation, and we need to do the same with our transcatheter approaches, and that'll require a combination. I think cord replacement's exciting too, and just how elegant that is.
There are lots of interest. Final question. you're going to be doing transcatheter mitral valve replacement. You think we're going to be doing those in a select group of people, or in 5 or 10 years there'll be more people that will be doing that?
Well, that's still a big debate about the relative indications for repair versus replacement. My sense is that replacement is going to require long-term oral anticoagulation, and will probably always be a little bit riskier than what we're doing with repair. My personal opinion is that we'll be repairing first and replacing second, but we've had great results with replacement in our hospital, and it works very well.
In selected patients.
In select patients,
Right patients.
absolutely.
Okay. Well, it's really exciting, and I appreciate that you've been one of the not only the experienced and knowledgeable operator, but a voice for really having the scientific look at it. So thanks very much.
Randy, you're gracious. Thank you.
No, I mean it. Thank you. Thanks.
Thank
you for joining us.